Welcome back. Today we are going to talk about meeting our residents' needs for restoring nutrition and elimination. So one of the first things we'll talk about is IV infusions. So an IV or intravenous infusion means that nutrients and or medications and fluids are administered through access to a vein. Now this is done by a licensed or registered nurse that has IV training. So what this is that a device is inserted into the vein and usually a short plastic tube is left. So they put a needle in, there's a little plastic tube over it, get the needle all the way in, and then pull the needle out and leave the plastic tube in place. So the fluid is administered by a gravity drip or an infusion pump. Now, your job as a CNA with the IV care is just to observe and document. You do not do anything else. You do not start IVs, you don't take them out, you don't mess with them, you don't troubleshoot them. Observe and document. So, understand that nutrition and hydration goals are part of that care plan. So, we may have a resident that has a care plan that they have to have IV fluids for 2 shifts and then they're done with it. And that's fine. But just know that those IV nutrition and hydration are part of the care plan. So, what we want to do as CNAs is we want to protect the tubing from kinks and pressure, just like we do our oxygen tubing. We have to make sure that our IV tubing is protected from kinks and pressure, because if you have kinks and pressure in the IV tubing, the resident's not going to get all of that nutrition or hydration that they need or the medication, and blood may start backing up in the tubing, and that would not be good. That's very, very scary for residents and sometimes their families if they see blood backing up in the tubing because the resident's not getting all of the fluids going in, and they may not understand why. So we want to protect our tubing while residents change clothing, turn in bed, and ambulate. So yes, your job as a CNA is to observe and document, but also protect that IV site. You will not be, doing anything else but protecting that IV site, observing and documenting. And I do have a little short video after this presentation that shows you how to change the gown on somebody, or substitute gown for shirt or whatever it is on somebody that has an IV tube going into their arm. So you want to keep that infusion site dry while the resident bathes. So this may mean that your resident may not be able to get in the shower necessarily, but most of the time they can. You can use different things like plastic wrap. Just take some saran wrap, wrap it around the IV site, and tape it. Some places will have special protective barriers, plastic barriers that you can put on that's kind of like a big clear sticker that will go over the IV site. Some places may have you wrap a trash bag around. Or if you have an IV site on the hand, they may have you stick the hand in, of course, a clean trash bag. We want to make sure it's clean. Stick the hand in a clean trash bag and then tape up the top so that water can't get down inside. Because if water gets down in that bag or onto the IV site, then that can cause the dressing to get wet and it won't stick as well. And then it may peel up and you might, lose that IV site, and that would not be good. So if you need to mess with the tubing, get the nurse. Besides just threading it through the clothing, if the tubing needs to be disconnected, it is not your job to disconnect it. If the tubing accidentally becomes disconnected, don't reconnect it. That's the job of the nurse. The IV tubing needs to be very carefully and specifically handled. Nurses are trained to do that, whereas CNAs are not, and that's okay. That you don't need that to be your responsibility right now. So if that tubing becomes accidentally disconnected, make sure that you notify your nurse right away. Blood pressures. We kind of talked about a little bit, not taking blood pressures on arms that have mastectomies or ones that have a dialysis graft. Same thing for IV infusions. You don't want to take blood pressures on an arm where there's an IV infusion. The way that IV infusions work is the catheter or the little plastic tube gets left in the vein, and the fluid goes into that and then travels up the vein to the heart to get circulated. So if you take a blood pressure on an arm that has an IV in it, you will occlude that vein and cause problems. The medication and the fluid won't go back up the veins to the heart, and you could cause a lot of swelling and damage. So just don't take any blood pressures on an arm that has an IV in it. If you have IVs in both arms, you may have to take a blood pressure in someone's leg. So hook up your cuff and take it in their leg. So, a resident who is not taking any oral fluids but is receiving IV fluids continues to need mouth care. So, anybody that's not taking in any oral fluids still needs mouth care regardless of whether or not they're on IV fluids. But just keep in mind that IV fluid may provide hydration, some some sense of hydration for that resident, but it's not going to provide everything. So you want to make sure that those people that are on IV fluids that are not able to take in oral fluids get their mouth care and keep their mouth moist, keep it healthy, keep it from getting nasty. So, some potential problems that you definitely want to notify the nurse of. If you have a drip administration where you don't have an IV pump present and it's just going by gravity, you can observe for continuing drips in the tubing chamber. Now, if the drips aren't coming or something looks like it's wrong, don't mess with it. Just go get the nurse. But you can see if it's running right or not. And that's something that you can always ask a nurse about and ask them, oh, well, is this, right? Is this what we're supposed to be doing? It kind of looks funny, but can you show me so that I can, make sure that if it does have a problem, then I'm able to recognize it. So, absolutely let your nurse know if there's a problem in that tubing chamber. So if it's a pump administration, there will be an alarm that will display and sound if the flow is blocked. Now, these alarms can be pretty loud. A lot of our residents will tune them out after a while. And if you've got a resident that's all the way at the end of the hall and you're up at the nurse's station on the opposite end of the hall, you may not be able to hear it, or the nurse may not be able to hear it. But if you start hearing that IV pump sound, then you need to notify the nurse. Do not turn the alarm off, because if you turn that alarm off and you go to find the nurse, you get stopped by another resident, oh, hey, I need you to come help me really quick right now. I'm about to fall out of my chair. Chances are there is a possibility you may forget to go tell the nurse that the alarm is beeping. Yes, that may happen anyway, even if you leave the alarm on, but that alarm's going to alert somebody else, or it's going to alert you when you go back out of that other resident's room. So you want to make sure to leave that alarm on so that somebody can still hear it, even if you get caught up or distracted or whatever on your way to tell the nurse. Another thing with that is eventually the alarm will start sounding again. So even if someone decides, oh, well, I don't want to listen to that, then they can hit the silence button on the alarm. It'll stop, but it'll start back up after about a minute or two. That's a good thing. So that if the nurse has not been able to get notified, and maybe the resident has pushed the silence on the alarm because they don't want to listen to it anymore, then somebody can still get notified and hear the alarm, let the nurse know that it's alarming. So don't ever shut that off, but if somebody does, then it will restart eventually. So you want to observe that that pump is operating. Make sure that it's plugged in. unless the residents, going to the bathroom or if they're having to go for a walk out in the hall. Otherwise, if they're in their room, either in bed or in a chair, make sure that it's plugged in because those IV pumps only have so much battery life. And eventually, the battery will die and the pump will stop operating and won't be sending all those fluids and nutrition to your resident. So, if you have the pump in the room, make sure it's plugged in. You want to observe the tubing. Report any blood backflow to the nurse. So the blood will start backing up in the tubing if you don't have the medication or fluid dripping continuously. Eventually, the pressure will need to be equalized, and since you've got direct access to that vein, then the blood will start backing up into the tubing rather than staying in the vein. Because remember, all of that blood in the vein is going the same direction as your IV fluids. So if you don't have those IV fluids in there to pump, to push the blood and continue it up the vein, then it's got a direct access to the outside of the body. So it's going to start backing up in your tubing. You want to observe the infusion site for redness, swelling, and discomfort. Sometimes you may see swelling in the absence of discomfort or redness. And this means that the IV has gone bad and the fluids are no longer pumping into their vein, they're leaking out into the other tissue. Now, this can be very, very scary if you have irritant medications in the tubing. So, if you have certain kind of antibiotics or other medications that are running, then that can really cause a lot of serious tissue damage to your resident if the IV goes bad and it starts leaking out into the tissues. Of course, this is not your job to determine if that's what's happening, but if you do notice any swelling, any redness, if the resident complains that it's burning, if they say, oh, this is really uncomfortable, it hurts, let the nurse know right away so that they can figure out what's going on. So, some other different alternative hydrations and nutritions, you can have tube feedings. Now, tube feedings are for residents who are unable to meet their nutritional needs by eating and swallowing. So, these feeding tubes have fluid or food that is administered through a feeding tube by a gravity flow or an infusion pump. The really neat thing about this is these go directly either into the stomach or into the intestine. So you don't have to worry about trying to swallow anything. You don't have to worry about, if you've got maybe cracked dentures and you can't eat correctly. Then this goes straight from outside of the body straight into the stomach or the intestines. Now, this is all going to be liquid. So with tube feeding, the unfortunate side effect of that is a lot of times you'll have people with real liquidy stools or real loose stools, and they don't smell very good. Poo doesn't usually smell very good anyway, but the tube feeding is going to smell a little bit different. And I think tube feeding kind of smells like stale Slim Fast anyway. But the G tube is the gastrostomy tube that goes directly into your stomach, and then a PEG tube is a percutaneous endoscopic gastrostomy. So this means that you have an opening in the stomach wall and through your skin directly into the stomach. So that feeding tube is for long-term use. This one is surgically placed, goes directly into the stomach through the skin, so you've got everything in place there. So you won't have to check to see, oh, is it in the right place or not? I mean, you do that anyway as a nurse or a med aide, not as a CNA, but it's in there. It's been surgically placed, it's in the right spot where it needs to be. It's a permanent thing. So the NG tube, this one's a little bit different. This one goes through the nose and down into the stomach. Now this one is going to be short-term use. If somebody gets an NG tube, it's in place, they're using it, and it's decided, okay, this needs to be a long-term thing, then they'll need to go to a PEG tube or a G tube to get it directly surgically in place into the stomach. So this NG tube, the problem with this one and why it needs to be short-term use is because since it's not, placed directly into the stomach, if it migrates and goes up, because it may move up into the esophagus or move a little bit further up, then if you're instilling tube feedings into that, it can get into the lungs and cause aspiration pneumonia. So that'd be a very, very bad thing. That's why it's very important for the nurses to be checking placement on that and making sure it's still in the right spot. You probably will not see the NG tubes a whole lot for tube feedings in a nursing home because they need to be checked by x ray to make sure they're in the right spot before you can give the first feeding. So the tube can also be used with other disorders to suction or remove stomach contents. So if you've got somebody that's got really, really super, super bad nausea, or they're trying to give their stomach a rest, maybe after surgery or something like that, then you might see that NG tube in place and have stuff going out rather than coming in. When you have someone with a tube feeding, there can be a lot of potential problems. One of the ways that you can avoid potential problems is to follow the care plan of how much angle the resident's head of bed should be at. And it's generally at least 30 degrees, if not 45 or more. So, absolutely pay attention to that care plan. What happens when somebody with a tube feed is laid flat is that tube feeding is in their stomach and it's all liquid, so there's no solid in there, but it's all liquid and it might come back up their esophagus and get right into the back of their throat and then go back down their trachea into their lungs. And that would cause aspiration, which can lead to pneumonia and all sorts of different issues. So some different signs of aspirations that you want to report immediately: if you have someone that's either coughing or choking, or if you see any tube feeding be spit up, or they have an increase in secretions from their mouth, those are all signs that you need to report to the nurse immediately. So if the person has a feeding tube pump, then during that feeding administration, observe that the pump is operating, that the fluid is flowing, that it's dripping into the chamber, because there's a big bag at the top and then it's got a little drip chamber and you can see the tube feeding come down in that. But it's not your job to make sure that that is going properly, but you can always observe and report it. So if the pump is malfunctioning, if it's not running right, then you need to let the nurse know so that they can fix it. So you want to be alert for gastrointestinal symptoms as well. Watch out for any nausea, vomiting, diarrhea, or constipation. Now, people with tube feeding are going to have a little bit different stools. It's kind of like having a baby that's breastfed versus formula fed, how it's just a little bit different. People with tube feeding may have more liquidy stools because there's no solid. They're not taking any solid in. If the tube feeding is their only source of nutrition, they're not eating any food. So their stools are going to be more liquidy and they may smell a little bit different. I know that's gross, but it's the reality of being a CNA. So definitely report if the resident, says that they're constipated, or if you notice that they're constipated, if they maybe are, got a grimace on their face like they're straining to have a bowel movement, or if they have a bowel movement that's starting to come out and can't get all the way out, maybe the resident doesn't have quite the muscle strength to push it out, then that's something to report right away so that the nurse can take care of it. So at the tube insertion site, you want to observe for any redness, drainage, or pain. This can all be signs of an infection. So any redness, swelling, drainage, pain, if it looks puffy, if it looks kind of angry, if there's crusty stuff around it from previous dry drainage, let the nurse know right away about that. Now, you as a CNA can observe the dressing that's around the tube feed insertion site. And a lot of times people, may or may not have a dressing. If they have drainage from that wound or from the opening, then they may have a split dressing around it. If they don't, if it's usually pretty dry, they may not have a dressing. So always follow your facility policy to see whose job it is to clean that site and put a dressing on. Sometimes they may have the CNA do it whenever they get them up for, the person up for the day. Sometimes the nurse may be the one to do it. Generally, it's cleaned with either a saline solution or maybe some hydrogen peroxide on a swab, just kind of swab around the site. And then there's a split gauze dressing that goes around it with just some simple tape. Not a complicated dressing to do, but definitely find out whose job it is, who's supposed to do it, and what your responsibility with it is. Whether it's your job or not to change the dressing, always report any of those signs of infection to the nurse right away. So make sure when you are moving the resident, repositioning them in bed, which yes, you can put their head down below 30 degrees to reposition them, but put it right back up. Or if you're going to get them out of bed, say you have to use a full body lift, you need to lay their head flat, that's fine. Try not to do it if they've just had a tube feeding. Try to wait a little bit, maybe like 30 minutes or an hour if you can. But if you are repositioning the resident, or if you notice the resident messing with their tube, please, please, please try to make sure that that tube does not get pulled too much, because it may dislodge or disconnect it. Now, the feeding tube, the ones that go in through the skin into the stomach, the PEG tubes or the G tubes, those are inflated just like a Foley catheter with a balloon inside. So it goes through the skin and there's a big balloon inside. But, if it gets yanked hard enough, that balloon can come out intact and just pop right out of the skin. So be really careful with those and make sure that those are taken care of and that they're not pulled on when you're repositioning. So if you have a resident with urinary output problems, then they may have a urinary catheter. So these devices are placed to collect urine, and our restorative goals are aiming to help the resident return to normal bladder function and control elimination. We try to put these in only on a very, very short-term basis, because if you think of it from an infection control standpoint, this is a direct line into the body. So if you've got, infectious material on that catheter, on the tubing, then it can go straight up into the bladder. That's why we clean it every shift and make sure that it's, clean, well taken care of, that there's no drainage, there's no swelling, that it's all looks like the way it should. But we want to get residents back to normal bladder function. That is our goal. So we have a couple different types of catheters. We have one that's called a Foley catheter or an indwelling catheter. This one is a tube that goes through the urethra into the bladder, and it's inflated with a balloon, with a water-filled balloon. So these, you have to be very, very careful, just like the G-tubes, not to pull them out, because that can cause a lot of urethral trauma and a lot of pain, discomfort, bleeding, and infection to your resident. We don't want that at all. So the urine will flow through the tube. So these people that have a urinary catheter will not have to go into the bathroom to pee, because the pee is going to be collected in a bag outside their body. Sometimes if the person is sitting just right and the balloon is kind of pressed up against the wall of their bladder, they may feel the urge to have to urinate, but they may just need to readjust and kind of get that urge, or the pressure taken off of their bladder from the balloon. So the catheter is connected to a drainage tubing and collection bag, and this is called a closed system, which means unless for some reason you are needing to change the bag, which we'll show you a video of how to change from that bedside drainage bag, the one that you see in the picture up there, to the leg bag, which was on the previous picture. If you don't have to change those out, then it's a closed system. That means you do not disconnect the tubing from the catheter itself. So that can be a really, really dangerous practice if you're not careful and use, good techniques in infection control. Because again, this is a direct line straight into the bladder, and you want to be really, really careful with that. So the interior of the catheter, the tubing, and the bag is considered sterile. That's why we want to make sure to keep everything, clean on the outside so that no germs get in there, because we want to keep it sterile and keep it a germ-free environment. So the use of the catheter greatly increases the risk for a urinary tract infection and other systemic infections. Now that urinary tract infection, that's pretty localized. It's an infection just in that urinary area. So just in the urethra, just in the bladder, just in that area. However, if the infection gets outside of that system and into the bloodstream, it can cause infection all over your body. And that's a systemic infection. That would really, really not be good. So we want to keep our residents free from infection. And a lot of nursing homes and facilities will use catheters, well, all of them use catheters as little as possible for this reason, because there is such an increased risk of infection. So there's some different types of catheters that you can use. One is called an intermittent or straight catheter. Now this goes in the same way that the regular indwelling or Foley catheter would, but it's only in and out. So you can also hear it called an in and out cath or a straight cath. The way this works is the tube still goes through the urethra into the bladder, but there's not a balloon at the end. So it does not get blown up. The bladder drains and then you pull the tube out. That's it. This is a lot better for infection control issues because it's not staying in the bladder. So this can be used to collect urine specimens or for other temporary use. So if you think that someone maybe has a UTI and they need a UA, then the nurse may be able to do an intermittent or straight catheter, get the sample, and get it back out. So if they're having somebody that's having a hard time voiding or going to the bathroom, or if the resident, we really need that sample and the resident says, well, I really don't have to pee yet, I've been having a hard time lately, then you can do that straight cath. So very, very temporary use. Another kind is a suprapubic catheter. This is another one that has a big balloon in it that goes into the bladder, but what this one does is this bypasses the urethra completely. So kind of like the PEG tube goes from the outside of the body through the skin and into the stomach, the suprapubic catheter goes from outside of the body through the skin straight into the bladder through a surgical opening. So that's pretty cool that they're able to do that. Now these you will need to do catheter care around the opening site, and that may be the job of the nurse, it may be the job of the CNA, and these need to be changed out about every month, just like any other indwelling catheter. Any other indwelling catheter really needs to be changed out every 2 weeks to every month if it's going to be staying in. But the suprapubic catheter, these are a pretty cool thing because a lot of people say they have, maybe some urethral trauma or maybe some narrowing of the urethra, that it's very, very hard for them to have, a regular Foley catheter in. Then that suprapubic might be a better choice for them. So you can have a different type of collection bag as well. Besides the big bedside bag, you can have a leg bag. So this is a smaller bag that's strapped to the resident's leg underneath the clothing, so you may not ever be able to see it, and that's kind of the point of the leg bag. So it's less visible than the larger bag, but it also holds a lot less volume. So this needs to be emptied a lot more frequently. If you have a resident with a leg bag, you may have them go into the bathroom and just empty it straight into the toilet, or you may empty it into, the graduate or urinal, and empty that into the toilet as well. So in the morning, a lot of times, whenever people are getting up and getting ready for the day, if they've had that bedside drainage bag at night, then what they'll do is have you change out the bedside drainage bag to a leg bag so the person can be up and be active during the day. So, some different care guidelines. We want to understand that inserting the catheter is the responsibility of the nurse. However, you as a CNA may be asked to assist with inserting that urinary catheter. So the nurse will have to use a sterile technique, sterile gloves. They can't touch anything besides what comes in the sterile packaging. But you may need to help position the resident in a supine position on their back and help maybe hold their knees apart or position the knees or hold a urine specimen cup. So definitely be aware that you may need to assist with putting a Foley catheter in. Understand that urinary elimination goals are part of the resident's care plan. We always go back to the care plan to see what our goals are and see why we need to do what we need to do for the resident. So you want to position the catheter where there's not any tension on the urethra. So if a person is sitting up in a chair, you want to make sure that that tubing is not stuck underneath their leg, or if it is under their leg, that there's not a lot of pressure on it, because that might pull and be really, really uncomfortable for that person and possibly make them feel like they need to go pee even if they don't. So some facility protocols may allow the use of a strap, such as the one you see in the picture, to support the tubing on the resident's upper thigh. Now, this will help two ways. It will not only protect the tubing from being pulled and being irritated, but it will also allow for more freedom of movement without that tubing kind of flopping around everywhere. So we always want to protect the tubing from kinks and pressure, and protect the tubing while the resident changes positions or ambulates. Now this is very, very important. When you have, especially that leg side or the bedside drainage bag, if you're getting someone out of bed, take that catheter bag with you. Be very, very careful of that. It's easy to forget the catheter bag, and then you are getting the resident up, putting them in a wheelchair, and pop, that catheter bag comes disconnected from the catheter itself. Or if you don't have the catheter firmly secured on the thigh, with a strap or some kind of sticky dressing device, then that catheter can come out of the bladder and cause a lot of trauma, and that would not be good at all. So please make sure that you take that catheter with you when you transfer a resident. So you want to position the tubing to allow for gravity drainage. One of the ways that you can do that is kind of loop the tubing on top of the bed. So you have the resident in bed, the tubing kind of goes over their thigh. So yeah, it has to go a little bit uphill, but there's really no getting around that. But then you want to kind of loop the tubing at a flat level on the bed so that the urine can drain, and then it goes off of the bed and down into the leg or into the bedside drainage bag. So we want to make sure to keep that drainage bag lower than the bladder to prevent backflow. Because think about if you've got a lot of urine in that tubing and it flows back up into the bladder, that can really, really increase your risk of infection and be very, very uncomfortable for your resident. You want to make sure to position the bag off the floor. That is so important. We had to say it twice. But you want to make sure to position that bag off the floor. If you're getting it near the floor, then you may have that bag cover, and that will help protect the catheter bag from hitting the floor. Because, again, infection control. If there's all those germs on the floor and the catheter bag is touching it, then the germs can get on that catheter bag and make it in the catheter bag and then travel up the tubing into the bladder. Scary, scary stuff. So we want to keep that off of the floor. You also want to position the bag out of the public view if the resident prefers. So if a person, say, is up in a wheelchair, they're going down to breakfast, they've got that bedside drainage bag, they don't do a leg bag. So you need to hang the bedside drainage bag under a wheelchair while they're being transported. Well, a lot of residents are not going to be too happy about having their pee bag be seen by everybody. So most people can still tell what it is even when you cover it up, but it just makes it a little less obvious. So you want to absolutely follow your facility's policy and keep your residents' dignity by using that bag cover. And this is not going to inhibit the function of the catheter bag at all, but it's just going to hide the urine from the sight of the other residents and visitors. So how to maintain a sterile system. We want to prevent introduction of organisms that can cause infection. So keeping the bag off the floor, make sure that you don't disconnect the tubing, or if you have to disconnect the tubing to change it over to a leg bag, make sure you don't touch anything. And there is a video after this presentation that will show you how to do that. So you want to maintain sterile connections whenever that system is open, so don't touch anything if you do have to open it. And make sure to disconnect or reconnect the catheter only when the task is directed by your supervising nurse. So if it's on the care plan to change it by a leg, change it out to a leg bag, that's the only time that you can really open the system. Otherwise, don't do it. So the nurse will verify that the CNA can maintain that sterile connection. So they may want to actually watch you when you change it over to a leg bag. You want to follow your facility policy for replacing drainage bags, because sometimes those drainage bags spring a leak. And if you see a trail of urine going down the hall after that resident that's in a wheelchair that's got a catheter hanging down there, you may want to check the bag and make sure that the bag has not started leaking. Now, when you go to empty the bag, that's another really, really good way to check as well, to make sure it hasn't sprung a leak. See if there's any moisture on the outside. That's a really, really good indication. Of course, you want to check with your gloves on, but you can see when you touch the bag and pull your glove away, you'll be able to see moisture if it's there. So the leg bag may be replaced each day or disinfected. A lot of times your facility and the resident will have, protocols and policies of how to clean those leg bags. Most of the time you're going to use maybe like a vinegar solution, vinegar and water solution, and run it through the leg bag and store it upright where it's going to dry. But whatever your facility policy is and whatever the resident prefers, that's what you need to go with. So when you empty that drainage bag, we want to absolutely use our infection control measures. Make sure that you follow the techniques that we're kind of describing. So you want to maintain the sterility of the system by carefully handling the drainage spout and bag. Whenever you empty the bag, then you'll open the drainage port, and some of them are different. Some of them have a button that you push and a little clamp slides over, and some of them has a clamp that pops open. Whatever it is, just make sure that when you empty that into the graduate container, that the graduate container is sitting on the floor, and you may choose to put a towel underneath it or paper towels, and that's fine, but the graduate container is sitting on the floor and the drainage bag is up above the graduate container. When you take that drainage port out of its holder on the bag, don't touch the drainage port to the graduate container. So again, if the graduate container has stuff on it, then that can be a direct line of infection straight to your resident. So empty the bag into the graduate container. When you're finished, make sure you get the drainage port closed. If you accidentally don't get that drainage port closed, you will learn very, very quickly your mistake because you will end up with urine on the floor, urine on you, could get urine on your shoes. That's not a fun feeling to have urine on your shoes and have it soaked through to your socks. Ugh, no. So make sure that you get that closed. And some facilities may want you to use an alcohol wipe and wipe off that drainage port before you put it back in its holder on the bag. And that's fine, whatever your facility policy is. If you choose to clean it with an alcohol wipe, even if your facility policy doesn't dictate it that it does, it's definitely not going to hurt anything if you do that. But definitely check with your facility policy. So you want to empty into a graduated container according to your facility policy, often every 8 hours. So at least once a shift, you will be draining that bag. If you work 12-hour shifts, you may be draining it twice, and that's fine, as long as it gets done. And don't think, well, I don't want to drain this, I'll just leave it for the next shift. Well, the next shift is going to drain it eventually, but it may be really, really full, and if it gets so full, then it might be hard, for that resident to move around with it. And especially if you have a leg bag that you don't empty properly or empty on time, that can start backing up into the resident. So please just take that few minutes and empty it, and be good coworkers to your fellow people and have it emptied during your shift. So if the person is on an intake and output that you have to measure the I and O and record it, make sure to measure it and record their output. Some people with Foley catheters may not be on I&O, and you just need to drain it and empty it. But those that are, make sure that you measure and record that output. You want to observe the urine for any abnormal properties. Is it clear, pale yellow? Does it have any white stuff floating in it? Does it look like it has any blood in it? Is it, a different color than that clear pale yellow? Does it smell stronger? Does it look concentrated? All those things can lead you to either, do they have a UTI? Are they dehydrated? What's going on with them? So you want to make sure to kind of look at that urine. And then you want to dispose of the urine in the toilet. Clean out your graduate container after that. Follow your facility policy. Sometimes it's even just rinsing it. But if you don't clean it out, that graduate container is going to start to stink. Ugh, that's gross. So make sure that you clean it out. So urinary catheter care, we have already kind of talked about how to do the perineal care and cath care a little bit, but we can recap it. So you want to start at the urinary meatus, and the urinary meatus is just the opening to the urethra on the outside of the body. So clean around that meatus, and then take your gloved hand, of course you're going to be wearing gloves already, take your gloved hand and hold on to the catheter, then with your other hand use a washcloth or wipe and wipe down the catheter. So wash that 3 to 4 inches of that catheter tubing with a clean washcloth, mild soap, or a wipe, whatever your facility policy is. But just make sure when you wipe down the tubing to hold on to the tubing at the top. That way you don't pull and dislodge that balloon or irritate the balloon. So your urine, when you look at it, when you observe it, kind of another recap, you need it to be light yellow, clear, nearly odorless, So that ammonia smell, that really strong ammonia smell, should not be there if you've got somebody that's well hydrated and that their kidneys are working properly and they don't have any infections. So you should observe the continuing flow of urine. If somebody, has spurts where they don't make any and then they make a whole bunch, but with that Foley catheter, there should be kind of almost a continuous stream. So check it every couple hours because you're going to be checking on your resident anyway. Take a look at their Foley bag, see if they've got some stuff in there. You want to make sure that you check for leaks. Make sure that you check for leaking of the system. We already kind of talked about, how to tell if the bag is leaking. Also look where the catheter bag tubing gets inserted into the catheter itself to make sure that that's secure, because that may leak if it's not properly secured. They may also leak around the catheter through the urethra. So pay attention to that. See if they've got any leakage around the catheter from their urethra. And if they do, let the nurse know, because that person may need a bigger Foley catheter if it's not fitting properly. So you want to check for any perineal redness or irritation. That can be a sign that that Foley catheter is moving around too much and just kind of irritating the skin, and it could also be a sign of infection. So you want to look for any indications of pain. If your resident says that it hurts down there, obviously that's a sign of pain. You also want to see, is your resident tugging on the catheter or tugging on their skin around the catheter? If they're grimacing when you do the catheter care, if they say ow, look for all those different signs of pain. So you can have verbal and nonverbal behavior, and just always report that to the nurse. So an alternative urinary elimination is the external catheter. Sometimes this is also called a Texas catheter or a condom catheter because it goes on just like a condom. So the device is a soft latex sheath with a drainage tubing at the end of it that hooks up to either a leg bag or a bedside drainage bag. Now these are less invasive, so they don't go actually into the body, but they're harder to kind of maintain sometimes. They may come off a lot more easy, and you have to change these out usually on a daily basis or when it leaks. So if you're going to put one of these on, which I've also included a video for this, you're going to wash and dry the penis. If the resident is not circumcised, place the foreskin in a normal, non-retracted position. Because remember, you don't want to retract it and then not put it back. That's very, very bad. It can be very painful for the person. So you want to roll the catheter sheath over the penis, leaving a 1-inch space at the tip. And if that catheter sheath uses a certain kind of elastic adhesive tape, you want to use that. So you want to secure it to the penis in a spiral pattern to allow blood circulation to tissue. So don't wrap it around, at the same spot on the penis and get layers of that wrap built up. So you want to start, at the tip and then kind of work your way down in a spiral pattern around. Again, you want to reapply daily or when leaking. So when you are putting these on or taking these off, changing it, you want to observe for any skin irritation and you want to observe for any leaking of the system. So what do we need to do when a resident has diarrhea? Well, let's kind of talk about what that is. So diarrhea is a semi-solid liquid or watery feces, often expelled with force and with abdominal cramping. So this is not a normal bowel movement. This is something that indicates that there's some kind of issue going on. So the intestines will normally remove any needed water from the digestive waste as it passes through the large intestine, and that will go back into the bloodstream. So that's what normally causes your formed stools. So the muscle movement that propels that food and liquid through the GI tract is called peristalsis. So it's kind of a wave-like movement. Whenever you swallow, if you take a big bite and you swallow something and you can kind of feel it getting pushed down your esophagus, that's like that peristalsis, and it works all the way down the GI tract. So, diarrhea can be caused by food, medication, infection, or other diseases. So, if you have a resident that eats something that maybe their stomach can't tolerate, say someone is lactose intolerant and they drink something and they don't realize it has milk products in it, that can definitely cause diarrhea. Certain kinds of medications can cause diarrhea. Sometimes chemo medications or radiation can cause diarrhea. Or if somebody maybe takes too much stool softeners or laxatives, that can cause diarrhea. Because I know that it's not your responsibility for medication, but generally, the biggest side effect for any medication is going to be what happens if it works a little too well. So, in the stool softener case or laxatives, it's going to be diarrhea. So, you can have different infections like C. diff that causes diarrhea, or some other diseases that cause just that malabsorption of water in the system and causes the diarrhea. So, some different things we need to do for a resident who has diarrhea. We need to, again, understand that our elimination goals are part of the care plan. Make sure to respond very promptly for a resident's request for assistance, because sometimes they may not be able to hold it that long. If they've got the urge to go, it's diarrhea, it's ready. They may not be able to hold it that long, so you need to help them right away. You want to clean the skin really, really well after diarrhea stools. Of course, we're going to do that after every stool, but that diarrhea may get kind of everywhere on the backside. Don't forget to look under the creases, the crease between the buttocks and the back of the thighs. Look in the front, because sometimes that diarrhea can get up into the front of the perineal area as well, and clean down the back of the legs. So just really, really make sure that you thoroughly clean, because that diarrhea may go kind of everywhere in that area. Then you want to apply protective cream if ordered. So sometimes diarrhea can be very, very irritating and can cause a skin condition called excoriation. Now, this is where the diarrhea and the acidity in the diarrhea kind of starts to irritate the skin and can make it very, very red and inflamed just raw. So we want to make sure to put creams on to help soothe the skin and protect it if the person has diarrhea. You always want to encourage increased fluid intake, because they're losing a lot of water with diarrhea. So you want to maintain that water balance and make sure that they don't get dehydrated. Document bowel movements, whether normal, diarrhea, or constipation. So if somebody has a hard stool that comes out and they said that, oh, this one was really hard for me to get out, I feel like I'm constipated, I can't, have normal bowel movement, you want to document that. Now, if you have diarrhea, sometimes the diarrhea, you can actually measure it as liquid. So if it is liquidy enough, then you can put it into a graduate container and measure it. And that's a good thing, just to make sure that you're, getting an accurate count of how much comes out. So you always want to document that amount. So you want to notify the nurse if they have any abnormal defecation or stools. So a normal stool or feces is soft, very soft formed, and it is brown. So you always want to report the color, consistency, and amount. And if you have somebody that has a different type of stool, or some change in their stool, then you need to save it for the nurse to see. So say you have a resident normally has soft form brown stools, you take them to the bathroom and they go to the bathroom and it's black tarry stool. That could be an indication that they're on an iron supplement. It could be an indication that they are bleeding somewhere in their stomach or intestines. So don't flush that. Make sure that you save that for the nurse to be able to see. So go let them know and don't flush that down the toilet. So you want to always observe for signs of dehydration, such as concentrated urine and dry mouth. Now, this is going to be especially important if you do have people with diarrhea, because again, they're losing all that water, and a lot of older people don't like to drink a lot, so they're going to become dehydrated a lot quicker. So, how about constipation? Constipation is something that a lot of older people deal with. It is one of their primary complaints. Older people sometimes are very, very concerned with their bowels and they like to talk about it. So they will let you know if they are constipated. So, constipation is the absence of bowel movements or stool that is hard, dry, and difficult for the resident to expel. So, it doesn't have a whole lot of water content in it, and it might be hard for the resident to push out. So, if you do not take care of constipation, eventually it may lead to a fecal impaction, and this is very, very dangerous. So, a fecal impaction is the accumulated of constipated stool in the lower bowel, and it blocks the normal passage of feces. Sometimes, if people get a bad enough impaction, they may actually have to have surgery to get it taken care of. Now, when you have somebody that has diarrhea, if they have a very, very watery diarrhea and it almost looks like just brown water, that does not necessarily mean that they are having just diarrhea. That may mean that they may have constipation or an impaction, and the water is the only thing that can get around it. So, that's another reason why we need to report that to the nurse so that they can figure out, okay, is this just liquidy diarrhea? Are they sick with something? Or are they really constipated and the water is the only thing that can get around it? And it's just kind of picking up some of the color from that stool that it's going around. So, it is not your job as a CNA to get rid of constipation or an impaction. However, you definitely can assist with that. So, not only identifying the constipation and reporting it to the nurse, but you may need to help with an enema. So, getting in that Sims position, where people are kind of on their side, on their belly, with their leg out and their arm out, that Sims position is the best position to be in if someone has to have an enema. Now, an enema is going to be either a soap and water based liquid, or it's going to be kind of an oil based liquid that is put into the rectum and it flows up into the colon to provide a lot of water, soften up all the stool, and allow for the resident to expel it. Now, that Sims position follows the natural line of the colon. So, if you've got that Sims position, you start an enema, it's a lot easier for the enema to go up into the colon because of the way that the colon is laid out in the intestines. So you want to kind of pay attention to that in the way that you position people. So understand that that manually removing that fecal impaction is the responsibility of the nurse. However, you can definitely be there for the resident, make sure that they're positioned correctly, and give them a lot of reassurance with that. So, impaction is manually removed from the rectum with gloved fingers. If you are not careful with it, or if the nurse is not careful with it, then you can do damage to the bowel wall if you don't do it correctly. So, definitely be there for that resident. Provide them reassurance, help them kind of, calm down, because it's going to be kind of a scary situation for some of those residents, or definitely uncomfortable. So you want to be there and kind of, provide reassurance and let them know that the nurse is doing everything they can to help them. So if you have somebody with an impaction, then you might see that liquid feces seeping from the anus, kind of like I was talking about. You may see smearing on sheets or the resident's underclothing, but they can't get anything out. And the resident may report rectal pressure or pain. So, following that treatment of impaction, you want to observe for the return of normal bowel function. Now, kind of going back to the enema, especially if you have somebody with an impaction, whenever they get an enema, it's the nurse's job to administer it, but you may need to assist the resident afterwards. So you want the resident to hold that enema in as long as possible. That way their body can naturally absorb that water and use it, to their advantage. So you may have to actually hold the buttocks together if a resident is unable to do that themselves. So you might have to hold for a few minutes. Have a towel hanging over the edge of the bed, so when the resident does get up, that if they do have some leakage or the enema starts coming out, that you don't get the bedclothes wet, or it doesn't cause all of the liquid to get on the floor, because not only would you have to clean that up, but it may be a slip hazard for the resident as well, so you don't want the resident to slip and fall. You may at this point want to get a bedside commode. Well, of course you're going to get a bedside commode before this even starts, but if you've got somebody with an enema and you don't think that they can make it to the bathroom afterwards, get a towel down on the side of the bed, make sure that there's a pad on the bed, have the nurse do the enema, you help them hold their buttocks together. When they're ready, get them up and put them on the bedside commode. That way they don't have to try to walk to the bathroom, because that can be a long walk if somebody's got all of that liquid in their bowels and they're ready to go. Because some of those soap suds enemas, you can put up to a liter in the bowels whenever you're trying to do that. And then the oil retention enemas, the little fleets enema, they're not very big, but that oil can definitely pack a punch where it needs to go. So the cleansing enema, this is kind of what I just talked about. Definitely you want to make sure that that you're able to help the nurse with this. So the nurse is going to have, the desired volume, have it at a safe temperature. They're going to lubricate the tip of the enema tubing and put it into the rectum. Then they're going to let the water flow in. And it's your job to help the resident hold it in as long as possible and get them some relief with the bedside commode when they're done. So then you have the commercially prepared and oil retention enemas. These are going to be just that little bottle with a tip on it, and you just take the cover off the tip. It's already lubricated. You may use some extra, that's fine, and then put it into the rectum and squeeze the contents of the bottle in. So both of these are going to be used to soften hard feces and to help the resident be able to expel the feces that's in their rectum. One of the ways that elimination can be restored is through an ostomy. An ostomy is a surgical opening into a body structure. So some common types are colostomy, an ileostomy, and a ureterostomy. So with a colostomy, an opening is made between the colon, which is the large intestine, and the abdomen to divert the bowel contents to the outside of the body. Now, with a colostomy, the way it's going to differ with an ileostomy is that it's going to be further down in the intestines. So the way that the normal bowel function works is when you eat something or drink something, then all of the contents go into your small intestine first. And the small intestine will not really take out very much water, so you're still going to have a whole bunch of liquid contents in there. Then it goes to the large intestine. The large intestine's job is to put all the water back into the bloodstream and, kind of make the contents more formed, and that's what forms your feces. So if you have the colostomy, depending on where you're at, in the colon, when the opening is made, then you can have more solid or more liquid feces. So just kind of keep that in mind. Now, if you have the ileostomy, this is where an opening is made between the ileum or the small intestine and the abdomen to divert the bowel contents as well. So this stool is going to be much, much more liquid. So this one you may have to empty a lot more often throughout the day because it's going to be a lot more liquid. Then you might have a ureterostomy. Now, this is an opening made between the ureter, that's the tube that drains the urine from the between the kidneys and the bladder. So before it hits the bladder, that storage area, you can get a ureterostomy, and that will divert the urine through the abdomen to the outside of the body. Now, these all will have a little pouch on the outside to collect everything. So the ostomy appliance, or the little bag, will fit over the colostomy or the ileostomy or the ureterostomy stoma, and that's the opening. It's a ring of muscle that's brought to the surface of the skin. So that stoma is going to be the opening. You're going to put the ostomy appliance over it to collect the feces or the urine. So the adhesive ring is secured to the skin. So there's going to be a really, really sticky ring that sticks on the skin. And then a collection bag or a pouch attaches to the ring. Now there's some ostomy appliances that have the two pieces like that, where there's that sticky ring and then the bag that attaches to the ring. And then there's some of them that are all one piece, where the bag is already attached to the ring and you just peel it off, have the sticky, and put it right on the skin. So just be aware that there's two different types, and I do have a video of how to change out those colostomy bags. And CNAs can change those colostomy bags out, ileostomy, whatever it is, as long as your care plan and your facility allow it. So understand that your elimination goals and the approaches are part of the care plan. So when feces and or flatus, and flatus is gas, because remember, it's not just the feces that comes out of our rectum, we also have the gas. So since the colon or ileum is going to be diverted to the outside of the body, it's not just the feces that's going to be diverted to, it's the gas as well. And that gas will build up in the bag and make the bag puff out. You need to change it, because if you don't change it, eventually that bag may pop off and all of your contents are going to go everywhere. So make sure that you empty that bag with that flatus, and whenever the flatus is emptied, or the gas, sometimes that's called burping the bag, because it does kind of sound like a burp or like a fart, when you normally have the gas. So make sure that you burp those bags very, very frequently if somebody has a lot of gas. So you may either empty or change the bag. So with a reusable bag, you can empty it in the toilet and then clean it following the facility policy. If you've got somebody with a lot more liquidy stool, you may be able to just put a graduate container on there and empty the bag and then clean the outside, or clean the end of the bag. With a disposable bag, you want to empty and discard it and then put a new bag on following your facility policy. So your care plan is going to dictate what kind of bag somebody is using. So it will let you know on the care plan. And then if you have any questions and the care plan is not clear, stop and ask your nurse. If you go in and you look at everything and you see it and decide, you're thinking, well, I'm really not sure if this is a disposable or not, stop and ask the nurse, and they should be able to clarify that for you. So when that adhesive ring leaks bowel contents, you want to make sure to remove and reapply it as directed by the nurse. Make sure that you clean and dry the skin around the stoma. This is very, very important, because if you don't clean and dry it and put that skin barrier on there, you could have skin breakdown or an ulcer formation. That is really, really hard to treat, because you still have to put that adhesive ring in the area of the ulcer. And eventually, if that ulcer is close enough, it can start eroding into the stoma itself. So be very, very careful with that. And if you are asked to change a colostomy bag and change the adhesive ring and everything, and you're not sure how to do it, stop and ask somebody. Until you get comfortable with that, just stop and ask somebody and see if anybody else knows how to do it, can walk you through it, or just make sure that you're doing the right thing. So you want to assist the resident or nurse with colostomy irrigation if that's used to regulate the bowel elimination, and the colostomy irrigation is similar to an enema. Now, some residents can do this themselves, and sometimes it'll be the nurses. You will not have to do this procedure. So you want to document the bowel movements, whether it's normal, diarrhea, or constipation. You want to check the care plan for approaches to managing flatus odor. So sometimes that gas, when it builds up, it's going to smell a lot different than the gas that normally comes out of our bodies. So it may have a stronger odor. So people may have dietary changes to help that, or some kind of deodorizer in the ostomy bag. They may have some kind of charcoal insert or something that will help cut down on that smell. So you always want to respect your residents' feelings about a colostomy, because they may have certain feelings towards their changed body image. They may be embarrassed. They may not want to talk about it. Some of them may want to talk about it. They want to teach you about it. You know, they have that colostomy. They may not be happy about it, but they want to teach you about it and teach you, the benefits that they have with it and how to take care of it. So just keep that in mind. You always want to make sure to show respect, show confidence, and acceptance. Because if you are not showing confidence, acceptance, and respect to the resident, they may not want to allow you to take care of them. And that's true with everything, not just the colostomy. So you always want to encourage your resident to be involved in their colostomy care. Some residents want to be involved, but they can't physically. So then you can ask them, okay, what do I need to do next? How can I do this the way that you like it? Ask them questions. And if they're, cognitively able to help you, but not physically, then absolutely ask them whatever you can and see how they are usually involved. If they can physically do it, allow them to do as much as possible and keep that level of well-being as high as you can. With the colostomy, you want to observe and notify the nurse of any potential problem. So you want to observe the resident's defecation, you want to report the color, consistency, amount, and frequency, and save some for the nurse if it appears abnormal. So if you have somebody that normally with a colostomy has a little bit, less formed than normal bowel movements, but not, real liquidy, and today they're real liquidy, then you want to let the nurse know and possibly save some to let them see it. So on the stoma itself should be a beefy red, and it should be moist, and the skin around it should be dry and pink. So if you have a stoma that looks really dry, or it's pale, or it's really, really super bright red, or dusky colored, or a different color than you normally see it, report that to the nurse right away, because that could be a sign of decreased circulation in that area. And if the skin around the stoma is starting to get irritated, you're seeing signs of an ulcer starting to form, let the nurse know that right away as well. So think about that more than 50% of the nursing homes population experience incontinence, according to the Centers for Medicaid and Medicare and Medicaid Services. So we want to promote any bowel and bladder continence that we can. We don't want to promote incontinence, but we want to promote continence, and we want to promote self-care with that as much as we can. So incontinence can come from different disease processes or injuries, such as multiple sclerosis, paralysis. If they have pelvic floor weakness, a lot of times women that have had a lot of children have trouble controlling their bladder, especially as they get older. So they might have weakness in those pelvic floor muscles. They might have an acute illness like a UTI or some other kind of infection going on. And it can be a combination of different conditions that can contribute to incontinence. So if you have impaired mobility, this can impair your ability to control your incontinence as well. So if your resident is not able to move independently to the toilet in a timely manner and they are relying on you, if they have impaired mobility, they may be continent, but if they don't make it to the bathroom in time, there's only so long you can hold it. And some people can hold it a lot less time than others. So people may also be disoriented. They may forget how to get to the bathroom. They may forget what to do in the bathroom. So they may rely on you to kind of help them through that, especially with people with dementia. So, our goals, we obviously want to restore the resident's ability to control a basic function as much as possible, maintain the resident's self respect and dignity, prevent embarrassment for the resident and their family, and we, of course, want to keep them at the highest level of well being as possible. Um, and think about other health problems. So, incontinence can be associated with falls, skin irritation, skin breakdown, and social withdrawal. Because some people, if they are incontinent, they may be embarrassed by it and they may stop going out to activities if they can't control their incontinence and they have that kind of issue. So, think about that as well. And we also want to meet that regulatory expectation. So not only is it the right thing to do to maintain that high level of well-being, but it's also a regulatory expectation as well, because incontinence is a functional decline. So if you have that functional decline of incontinence forming or incontinence getting worse, and there's no documentation to back it up, that yes, we've been trying all these efforts, but despite our best efforts, they're still declining, then your facility could get a tag from the surveyors, and that would not be a good thing. So there's some toileting assistance programs that usually are made up by either the MDS coordinator or the RN or possibly even the therapy department. So our goal is for all of our residents to be clean, dry, and free from odor. So the program is going to be individual for each resident. It's built from information about the resident's pattern of incontinence and the resident's specific needs. So the type of incontinence that the resident experiences is identified. So think about your resident that is completely functionally incontinent, that they don't know when they're going to need to go. When they go, they don't know that they have gone. So they are just completely incontinent. There's no way that they can control it. We may need to get those people to the bathroom more often and try to kind of catch it. Or you have the people that when they need to go now. And it hits them, they have maybe a few seconds and then it's done. So those people may need to have their pelvic floor exercised and get their muscles strengthened a lot more, and then also start some kind of a preventative toileting plan, get them to the bathroom before those times hit. So some people may have a very specific pattern of, okay, I know that I am going to need to pee at 3 o'clock in the afternoon. I can't really hold it, so I really need to kind of figure this out. So that may be something, say at 2:30, that the resident gets toileted, and that they, use the bathroom, and then maybe that cuts off that 3 o'clock incontinence. So there's always a reason behind it. You need to figure out what the reason is and try to figure out what we can do about it. Now that is not your job. That's, the nurse's job, the occupational therapy department, and whoever, but you can still contribute that information to that care plan. So your plan may also include mobility goals, since mobility is important in achieving continence. So think about the resident that may be incontinent because they can't make it to the bathroom in time. And they feel the urge, they can wait a couple minutes, but they're trying to get to the bathroom. Maybe they have to wait for somebody to come walk them. So their goal may be, okay, if I can get myself to the bathroom in time, I won't have any incontinence. So they may have that mobility goal as part of their care plan. So bowel incontinence is also important. We want to make sure to maintain as much continence as possible. So you want to follow the care plan guidelines for any kind of pattern or toileting program that they have for that, because people may be able to be continent of bowel but maybe not continent of urine, or continent of urine but not continent of bowel. It really just depends on the person and what their needs are. So you always want to follow your care plan. So you can use different medications that can help regulate bowel elimination, and just know that that resident can experience both bowel and bladder incontinence, and your care plan will address both of those needs. So there is a program called prompted voiding. This is where the residents will learn to recognize bladder fullness and be able to respond when prompted to urinate. So you're going to check every couple hours, ask if the person is wet or dry. You want to check for wetness and give feedback. So if they're wet or dry, either one, ask if the person wants to use the toilet. If they say yes, make sure that you assist the resident with toileting, record the results, and give positive reinforcement, because we always want to give positive reinforcement. Don't ever embarrass the resident if they have already, been incontinent and you take them to the bathroom anyway and they can't do anything. Don't ever scold them for that. Not only is that going to hinder their progress, but it could be verbal abuse if you're just not being very nice about it. So always, always, always give positive reinforcement. So if the resident says no, and they say, oh, I don't need to go to the toilet, if they have not voided in the past 4 hours, and if they're dry, repeat the question of needing to use the toilet. So if they say, no, I don't really need to go, they've been dry, and they haven't peed in the last 4 hours, ask them again. If the resident says no again, tell the resident that you will return in 2 hours and ask them to try to wait until urinate until then. So if they start feeling that urge, then try to get them on schedule. Of course, if they feel the urge and they really can't wait, then you want to have them call you, because you don't want somebody to be incontinent or to try to take themselves to the bathroom. And because if you say, well, I'll be back in 2 hours and we'll try to go to the bathroom then, well, they may take it as, okay, I'm not going to see her for 2 hours, but it's been an hour and I need to go, so I'm just going to take myself. Some of your residents may do that, so absolutely encourage them to call you if they need anything before that 2 hours is up. So we can have different habit training programs. This is where the staff is going to monitor and record the resident's voiding pattern. So this may help find a predictable pattern. So say your resident voids, when they wake up, once after breakfast, once before lunch, once at 2 o'clock in the afternoon, maybe right before supper, and then right before bedtime. So this is going to help strengthen that habit. If we find the pattern, then we can help take them to the bathroom at those times and help stick to their schedule. So then we can have also a scheduled voiding program where the resident toilets on a regular schedule, such as every 2 to 4 hours during waking hours. So you're going to take them to the bathroom. Whether or not they actually go, you're going to take them into the bathroom every 2 to 4 hours, have them sit on the toilet, and the goal is to toilet at the intervals that will allow the resident to stay dry. So this may be a good option for some people. Then we have bladder retraining, where the resident is taught to consciously delay voiding or the urge to void as a part of a plan to regain voiding control. So if they've been incontinent and their bladder muscles still work, and there's a chance that they could be continent, that's when we kind of help retrain them. And sometimes places will do this with a Foley catheter before they take it out, because when you have that Foley catheter in, those muscles that keep all the urine in the bladder are not being used, so you may have to kind of retrain them to figure out what they're supposed to be doing. So your role with the toilet assistance program, you want to collect all the information and follow that facility protocol. Sometimes you may be asked to write down on a piece of paper on the back of the door all the information, or chart it just in the regular charting. You want to check the residents for continence every hour or two during waking hours and at longer intervals at night. You want to accurately record intake and output. Follow that toileting assistance plan exactly and consistently. So there's a reason why it's there, not just for fun. So there's a specific reason why we're following that care plan. So you want to recognize the priority of toileting as you organize care for multiple residents. So say you have a resident that wants to get up and get dressed, you've got another one that's ready to go down to breakfast, and you've got another one that needs to go to the bathroom. Make the bathroom your priority. So always make that toileting your priority. And then you want to make sure that you reflect patience and do not criticize a lack of continence. So this concludes our PowerPoint presentation over restoring nutrition and elimination. We've got a few videos just for some of the skills for you afterwards. If you have any questions, please contact your instructor and have a great day.